Annette, who has recently been diagnosed with an advanced reoccurrence of pancreatic cancer, which has now spread to her liver. She lives with her husband, who is visually impaired, and she's his full-time carer. Whilst attending day hospice, she meets with her palliative care clinical nurse specialist to discuss completing a ReSPECT document to sit alongside her more detailed advanced care plan. Annette has been given a ReSPECT information leaflet at a previous visit, and after discussing matters with her husband, was now ready to have the conversation. Annette and her nurse specialist agreed that her priority for care is maintaining comfort, and that if her heart stopped, resuscitation attempts and admission to an intensive care unit would not help her to achieve her goals of comfort care. Annette mentioned that she did not want to die at home, as she thought it would be too distressing and difficult for her husband. However, they agreed that she would want to be considered for some treatments, such as intravenous antibiotics and blood products, if the benefit of treatments outweighed the burden of treatments. During the ReSPECT conversation, Annette shares her anxiety regarding ongoing care for her husband, and she will no longer be able to care for him. A summary of these discussions and agreed recommendations were recorded in Section 4 of Annette's ReSPECT form.
The plan should stay with the person and be available immediately to health and care professionals who are faced with making immediate decisions in an emergency, where the person themselves has lost capacity to participate in making those decisions.
Some months later, Annette wakes in the night shivering and sweating and feeling very ill. She calls an emergency ambulance. The ReSPECT form is reviewed by ambulance staff before taking her to the local emergency department, where she is found to have a chest infection and admitted to the respiratory ward. The ReSPECT form is handed to the admitting nurse. Annette improves slightly with intravenous antibiotics. Her recovery remains uncertain, and the Amber Care bundle is used to discuss a parallel plan for care if she worsens despite active treatment. Annette's main concern is her husband and who is looking after him at home while she is in hospital. She is reassured as the ward nurses contact the social worker and GP surgery to alert them of his needs. 7 days after her admission, her symptoms worsen. Annette is taking very little to eat and drink, sleeping most of the day, and is unable to mobilise. Annette and her husband are seen by the hospital palliative care clinical nurse specialist, and they review her ReSPECT form. Annette's preferences for comfort of care are clear, and she agrees continued treatments are no longer benefiting her. They discuss that Annette appears to be in her last days of life. They agree that ensuring that her symptoms are controlled and providing supportive care on the ward is her best interest. The ward team use an individualised last days of life care plan to support the care they offer to Annette and her husband, and allow her to die with dignity in hospital.
ReSPECT documentation includes a resuscitation recommendation within the nationally recognisable document and will replace the nationally varied DNA CPR forms. DNA CPR forms should be recognised as valid in an emergency situation, as there will be a substantial period of transition whereby historical decisions have been documented on DNA CPR forms and will still be with patients. As soon as it is appropriate to do so, a wider ReSPECT conversation should take place and the recommendation should be reviewed and transferred onto a ReSPECT form.